Hello everyone, we are going to talk about the open fractures. So let's start. The learning objective of today's video, or you can say lecture, is to explain the mechanism and cause of open fracture, classify open fractures using Gastillo-Anderson classification, describe the emergency management of open fractures, discuss definitive treatment options, recognize the complication of open fractures. So, introduction. What is open fracture? Open fracture is one of the most serious orthopedic emergency because of the fracture communicate with the external environment, exposing bone and soft tissue to contamination. Early recognition, antibiotics, surgical debridement, fracture stabilization, soft tissue management are essential part to reduce the infection and improve the outcome. Why the so important open fracture to discuss? Because they carry the high risk because of infection, soft tissue damage, chances of non-union, osteomyelitis, limb loss or neurovascular injury. The causes of open fracture. There are high energy trauma, low energy trauma. High energy trauma, road traffic accidents, industrial accidents, crush injury, gunshot injury. These are high energy trauma which leads to open fracture. Low energy trauma, fall from standing like in osteoporotic bone, sports injury. These are less common. Mechanism of injury, the opening of the fracture site, either outside in or inside out. Outside in means object penetrate from outside, that leads to open fracture like bullet, knife or any machine injury. Inside out, sharp bone fragment pierces the skin from inside out. So it is the most common mechanism. Clinical feature, in open fracture patient we will have the severe pain, bleeding, inability to move the limb and the deformity of the limb. Signs, you will find the open fracture near fracture bone may or may not be visible in the open wound. There can be swelling, tenderness, crepitus, abnormal mobility, neurovascular injury. In any open fracture patient or in closed fracture patient, you do the primary survey like XABCD. EX means exudating bleeding. Then A for airway, breathing, C for circulation, D for disability, E for exposure. Then you do the secondary survey, detailed examination and assessment. Then you classify the open fracture based on Gastillo-Anderson classification. In the type 1, the wound is less than 1 centimeter, clean wound, minimal soft tissue damage, and it's simple fracture. Type 2, wound is 1 to 10 centimeter, moderate soft tissue injury, no extensive tissue loss. In type 3, there is a high energy injury energy injury with extensive soft tissue damage, divided into 3 subtypes. Type 1, 3, type 3A, there is a severe soft tissue injury, adequate soft tissue available to cover the bone. Type 3, there is a 3B, extensive periosteal strapping, bone exposure require the flap coverage. Type 3C, associated with the arterial injury which requiring the repair. So in type 1, less than 1 centimeter wound, minimum soft tissue bone coverage possible. 2, 1 to 10 centimeter, soft tissue coverage moderate and the bone coverage possible. Type 3, more than 10 centimeter wound with soft tissue damage and bone coverage possible. Type 3B, there is extensive wound with severe soft tissue damage and bone coverage not possible, require the flap. Any size of wound with severe soft tissue injury and the bone coverage with arterial injury is considered as the 3C. Any patient comes with open fracture, you do the investigation, imaging, X-ray, do the AP and lateral view, which includes the one joint above and below. We do the CT scan to rule out the intra-articular fracture or complex injuries. Then laboratory testing, these are done after patient stabilization. CBC, blood grouping can be done in an emergency when there is a extensive excessive bleeding. Blood sugar, renal function, coagulation profile, or wound cultures are not routinely recommended before debridement as they do not reliably predict the infecting organism. So, management in the step 1, you follow the ABCD. Step 2, you control the bleeding by direct fracture or sterile dressing, avoid blind clamping. Step 3, assess the neurovascular status, document pulse, sensation, motor function. 3, cover the wound with sterile saline soaked dressing. Do not probe the wound. Do not attempt to push the exposed wound back inside. Step 5, immobilize the limb, spleen, temporary external fixation. Start IV antibiotic, administer as early as possible, ideally within 1 hour of injury. Then in type 1 and type 2 wound, first generation cephalosporin cefazolin given. In the type 3 wound, first generation cephalosporin plus aminoglycosides. Additional anaerobic coverage can be given or may be considered for firm injury or gross contamination. Then you give the tetanus prophylaxis and urgent orthopedic consultation. Surgical management. Any open wound managed through step by step. The first step in any open wound injury, open fracture, is the remove the contamination, reduce bacterial load, remove foreign material. It is done by copious volume of sterile normal saline. Low pressure irrigation is generally preferred to minimize the soft tissue damage. Surgical debridement, it removes the devitalized tissue or foreign bodies, dead bone, contaminated material. And the principle is solution is the pollution. Solution to pollution is the dilution. Fracture stabilization. There are various methods to stabilize. In emergency, you place the slab and external fixation in selected case. For the definitive, you can go for intramedullary nailing, plate fixation. Choice depend on fracture pattern, soft tissue injury, and patient condition. Soft tissue coverage can be primary closure, skin grafting, local flap, free flap, and the early soft tissue coverage, ideally within 7 days when feasible, improves the outcome. Principle of open fracture management, there are 5 C's: cleaning, cutting, coverage, construction, and combat the infection. There are complications which are associated with open fracture are hemorrhage, infection, compartment syndrome, neurovascular injury. These occurs in the early phase of the injury. Late after treatment, there are delayed union, non-union, malunion, chronic osteomyelitis, implant failure, limb shortening, and amputation. Factor affecting prognosis are better prognosis if there is early antibiotic administration, thorough debridement, good blood supply, stable fixation, or early soft tissue coverage. Poor prognosis are severe contamination, delayed treatment, vascular injury, smoking, and the diabetes. So, a 30-year-old male motorcyclist present after a road traffic accident with 7 cm wound over the tibia, exposed bone, extensive muscle injury, distal pulse are palpable. So, it is the wound is less than 10 cm. Extensive exposed bone means there is a periosteal stripping. So, it is the 3B. What are priorities in the emergency management? Priorities in emergency management in such patient is the first, control the bleeding. Any exposed wound, first you assess the wound, thoroughly wash the wound, then If it is possible to reinsert the bone after traction, if it is easily going inside the limb, then it's okay. Antibiotic, you start the either ceftriaxone, amikacin, third generation, cephalosporin, या piperacillin tazobactam. First, you need to debride the patient. Thoroughly debride. If the skin condition or coverage is possible, then you go for primary fixation. Otherwise, staged fixation. So, every wound near a fracture should be considered a open fracture until proven otherwise. Early intravenous antibiotics are one of the most effective measures for reducing infection. Do not explore or probe the wound in emergency department. Thorough surgical debridement is the cornerstone of treatment. Early stabilization and timely soft tissue coverage improve fracture union and reduce complication. Often fractures are the orthopedic emergency due to the high risk of infection and soft tissue complication. Early intravenous antibiotics, tetanus prophylaxis, sterile wound coverage, and splitting are the key emergency measurement. The Gustello-Anderson classification guide the treatment helps to predict the prognosis. Irrigation, meticulous surgical debridement, stable fixation, appropriate soft tissue coverage are the cornerstone of definitive management. Early multidisciplinary care involving orthopedics, plastic surgeon and the vascular surgeon when required leads to the best outcome. Thank you.